Hello, everyone. This is Chris Sosa with Becker's Healthcare. Thank you for joining us for today's webinar, How Boston Medical Center Created 3,200 Plus Days of New Capacity. Before we begin, I'll walk us through a few quick housekeeping instructions. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you have issues with audio visuals, please try refreshing your browser. You can also submit any technical questions in the Q&A box, as we are here to help. With that, I'm pleased to introduce today's speaker. We have Dr. Chris Manasseh, MD, Associate Chief Medical Officer of Inpatient Operations for Boston Medical Center, and we have Jason Cohen, MD, Chief Medical Officer of Inpatient for Cuventus. Thank you, Dr. Manasseh and Dr. Cohen, for being here today. I will now turn the floor over to you to get us started.
Thanks so much. And thanks, Chris, for joining us today. Looking forward to the conversation.
Excited to be here.
I'll share the agenda with everyone first. We're going to hop through some introductions, and then I'll turn it over to Chris to talk about the different opportunities and challenges they had at BMC. I'll share a bit about the Cuventus inpatient capacity solution, and then we'll talk about the outcomes we were able to drive together, and hopefully leave at least 10 or 15 minutes at the end to answer folks' questions. You all should see a box on the side of your screen there that allows you to enter questions. Please do that throughout. I'll try to get to those as able in real time, and then we'll try to get to as many of those that we weren't able to at the end of the discussion. But thanks everyone for joining us today. I'll start by just telling you a little bit about Cuventus. We've actually been working to help hospitals and health systems meet their mission for over a decade. You can see a lot of the partners that we're proud to work with on this list here. I think as a clinician, the thing I'd say I'm proudest of is that third bullet at the top, that 100% of clients see us as part of their long-term plans. I think that speaks a lot to how we partner with folks. I'm one of many clinicians on the team. We strive to deeply understand the challenges that frontline teams face today, and create solutions that meaningfully reduce the burden on those teams while enabling hospitals to meet their mission. We're pioneers in machine learning models, building sophisticated models to help hospitals. But probably what we're best known for is how we operationalize those models. So one thing to build models, quite another to figure out how to integrate those into existing workflows for care teams in a way that meaningfully reduces manual burden and actually improves the patient experience, decreases excess days, et cetera. That automation of and integration of machine learning models is built into each of the solutions on our platform. First, that perioperative care coordination solution, all about getting patients prepped for surgery. We have a industry-leading chart mining technology that enables us to read through the EHR, through the ambulatory record, through the HIE, to find over 230 different risk factors for surgery and assign appropriate ASA score, triage those patients, make sure they get the right care before surgery to help health systems reduce cancellations, improve outcomes, and find opportunities for optimization. Our surgical growth solution, which helps health systems find strategic white space and fill it with those cases that are most important from a growth perspective. We have an exclusive relationship with Intuitive that enables us to help health systems particularly increase their robotic volumes and add up to 3+ strategic cases per month per OR. The inpatient capacity solution we'll talk a little bit more about today, and then our latest solution is the care gap and coding automation solution. This is an end-to-end solution to help health systems identify the clinical complexity of the patients they care for, to make sure those patients get the right care and that you're adequately capturing that medical complexity and documentation. Really important both from a quality perspective as well as a reimbursement perspective. That's a little bit about us. I'll turn it over to Chris now to talk more about BMC.
Thank you, Jason. Excited to be part of this webinar to talk about Boston Medical Center. We've been operating since 1855 for the last 170 years, providing exceptional care for all patients. that's equitable with the expertise. And in the last 20 to 30 years, we've made a lot of changes. In 1995, we established a coordinated delivery network with 12 community health centers. We also are the largest Medicaid managed care organization in the state of Massachusetts, providing care to vulnerable population since 1997. And in 2022, we actually created behavioral health services with 106 beds dedicated to serving patients with complex mental health and substance use disorder conditions. Over the last couple of years, we've expanded to two other campuses, one in the south of Boston and the other in Brighton, and adding bed capacity and providing expert care. In terms of our journey in looking at how to improve patient flow, we were confronted with a couple of challenges. The first one is that our processes for discharge planning were not standardized. And what we needed was something that everybody could adopt, ideally a tool that would help us establish a workflow that could be followed. Secondly, we were spending a lot of time on patients that were outliers and missing out on patients that mostly went home because we couldn't get the information in a timely fashion. And finally, it was putting a lot of strain on our resources where folks were spending a lot of time manually doing tasks. And it was difficult to scale improvement efforts.
I'm on mute, sorry about that. Chris, can you share with folks anything that you tried in the past to address these problems that either worked well or didn't work?
Yeah, we always wanted to do a standardized multidisciplinary round, and we had our fits and starts over the last 25 years that I've been part of the organization. That wasn't something that we could do in a sustained fashion. What we really needed was something that was structured, something that was agreed upon by the 18 different teams, including specialty services, both medicine, surgery, pediatrics, maternal child health, and we needed it to be consistent. We needed a process and we needed a tool. And we couldn't wait time. There wasn't time that was affordable. We needed something that could be quickly delivered. So the options that we had were not working for us.
Great, thanks for sharing that. We're actually going to hop into a poll real quick just to get people kind of engaged. Curious how folks listening today, how you're currently tackling these problems. It certainly manifests lots of different ways, whether that's ED boarding, PACU holds, extended length of stay, transfer refusals. If you all want to answer the poll you see on your screen here, which of those would be your answer? I'm seeing 2 of 147.5. There we go. People are starting to submit. And then the next screen will go ahead and show the results. Chris, if you had to, it sounds like from what you were just saying, well, I won't give you the answer. What would you have said your situation was when we first met you of these 4?
Well, I would say probably D.
So a lot of manual work.
Yeah.
All right, we've got about 40% of people responding, a couple more trickling in, and then we'll do the big reveal. All right. So folks here, yep. It's a top, so it looks like the one that won here, top priority, but we haven't found the right solution yet. And then a second, managing it manually, heavy lift on our teams. Yeah, interested if anyone wants to throw anything, if there's any nuance you want to throw in the Q&A on that. Um, I'd say from my own experience, and Chris, interested in hear what you'd say here. I feel like we've been doing this for over a decade. Like that, I was at a recent Bree Network conference, I think in New Orleans or Texas or somewhere, and we were talking about the problem of patient flow. And it's almost a shame on us moment where we've been talking about improving patient flow for so long that we're still having the same conversation at conferences, but just not feeling like people feeling like they haven't found the right tool or not having an impact. Is that your sense of it of the last decade? Do you think we've made, and then obviously we'll talk about our own progress together, but as an industry, as a health system, do you find that to be the case?
Yeah, I think especially it's true in an academic medical center and more so in a safety net environment. I would agree.
Yeah, a lot more complexity. Well, let me share how Qventus approaches this problem, and then we'll let Chris share the results at Boston Medical Center and turn toward more of a discussion. We call this the windy road slide. It's kind of the twisty-turvy path that both providers as well as patients have to walk between when patients actually get admitted to the hospital and when we're able to discharge them. A lot of reasons this isn't a straight line path. Chief among them is probably just the complexity of patients we care for. I think all of us are seeing increasing CMI. We have more responsibility for sociodemographic factors, and just the sophistication of the care itself that we deliver. On the other side, you have a lot of manual processes. So I was trained as a hospitalist. I still work a couple shifts a month. And you have providers walking around with printed out patient lists and handwritten check boxes and case managers faxing things. It's just a lot of daily manual heroics to try to get patients what they need and get discharged on time. So not really a surprise that when you have very complicated system dependent on a lot of manual tasks and aren't very reliable, that you're going to end up with a lot of waste. And that's 20 million excess days annually in the country. We have ED boarding times that are an all-time high. That's PACU holds as well. And not a problem we're going to solve with more staff. The staff isn't there. If we're going to meet our mission to our communities, we're going to have to get better at delivering care with the resources we have. The truth is we've thrown all kinds of answers at this over the last decade. We build discharge lounges, or we harass providers to put in AM discharge orders, or we have extra huddles. All of these things, I would say, are well-intentioned. Sometimes we get a little bit of a benefit out of these, but in the end, we end up backsliding. And the reason is that it's just more manual work for care teams that are already super busy. And so that's not going to be sustainable. I think one of the lessons from the quality movement of the last 10 to 15 years is that if you're going to have a sustained impact on a problem, you really, there's a couple of things you have to do. First, you have to make sure you give the folks doing the work the right tools to succeed. You need to make sure those tools are purpose-built for the outcome you're trying to drive. And then finally, you need to embed that in existing workflows. You can't expect busy care teams to go to alerts or dashboards or separate systems and see something and then come back later and take action. Like, you have to make it live and breathe in their daily work for it to be sustainable, scalable, and deliver consistent outcomes. And that was really the core philosophy behind how we built the inpatient capacity solution. So that solution is built on 5 core AI assistants. The first of those is the discharge planning assistant. So that discharge planning assistant sits on top of a suite of machine learning models that we hyper-tune to each individual hospital. So not like national medians or averages or anything like that. These models are trained to your patients, your providers, your care patterns, et cetera. And they populate an estimated date of discharge and disposition directly in Epic or Cerner by the first morning after admission. So when your care teams come in, everyone has a plan in place to align around for every patient. And those plans are personalized to each patient. Again, they're not an average or a mean. We do pull in national benchmarks like GMLOS, so we can identify those places where there's opportunity to improve performance and continually nudge care teams to those slightly more aggressive but achievable discharge plans that enable you to reduce your excess days. The second assistant is what we call the care gap assistant. And this assistant is populating in real time the specific milestones for each individual patient. And that's powerful by itself, like creating that reliability and that transparency. A lot of folks have milestones today, whether that's in Epic or Cerner, but they tend to be hugely manual. And because they're manual and relying on busy care teams to update, they just don't end up being reliable. So we populate and resolve these milestones in real time through automation. But then we take it a step further. And that's what's really important. Like, you've got busy care teams. You can't just always rely on the right thing happening. So in this case, we'll actually prompt the next action to close that gap in the patient's care, whether that's populating an order for a provider, nudging a nurse to remove a catheter, suggesting to a case manager that they need to get facility preferences for a patient heading to post-acute care, whatever the case may be. Like, important to have that transparency, but even more important to be biasing towards action and prompting the resolution of that gap. The next assistant here is the case manager assistant. As probably most folks that are on the webinar today know, case managers are just so important to the overall discharge process, and they're super busy, typically seeing 20 to 30 patients a day. Keeping up with all the things your patients need and making sure those get done before they're ready for discharge, a huge task. And so this case manager assistant actually is reading all the notes in real time and identifying any discharge salient tasks and then surfacing them within the EHR, again, Cerner, Epic, et cetera, so that your case managers can easily see the things their patients needs and prioritize them accordingly. So think things like, this patient is going to need 2 weeks of outpatient IV Vanco. This patient needs a wound vac. This patient needs a follow-up in stroke clinic. Whatever the case may be, pulling that stuff out of the notes so it's easily visible to your case managers so that they can take action on those before they cause a delay. Whole other set of capabilities there around making sure that you're making the best case for patients that you're sending to post-acute care. So imagine a patient going to acute rehab. That case manager assistant will evaluate that patient's candidacy, make suggestions for how it can be improved, looking at criteria like medical complexity, CMS 13 diagnosis, whether they're being seen by 3 therapies, et cetera, and make suggestions for how you can improve that application. Whole idea here is, let's pick the right patients for the right disposition. Let's make the best case for them we can so we can increase your first pass payer approval. Next assistant's the flow priority assistant. And this tends to be everyone's favorite assistant. This is an assistant that sits on top of each of your ancillary work lists in Epic or Cerner and orders all of those pending orders in the sequence that will most optimally support patient flow. So instead of today, where a lot of health systems, this tends to be first in, first out, or everything getting ordered stat, the idea here is this complex AI algorithm, which involves multiple machine learning models, looking at the interval impact of completing that order for each patient that's waiting for it, optimally sequences those patients, again, directly in that work list for those care teams so they can easily take patients in the order that's best going to support patients being able to discharge on time. Maybe a place today where you have really highly motivated ancillary managers or providers or even nurses calling them and saying, hey, can you see my patient next? We're trying to get this patient out. That needs to be automated. That needs to be easy to do. Can't rely on manual efforts from just your most effective providers, nurses, and case managers. Last assistant's our capacity intelligence assistant. This assistant does exactly what it's named for. It gives you insight into what your capacity is going to be tonight, tomorrow morning, tomorrow night, et cetera. When you're creating those highly reliable discharge plans and doing all the work on the backside to help care teams achieve them, that enables us to be a lot more confident and give you high reliability around what your capacity is going to be going forward. Whole other set of admission models looking at patients coming from your ED, from your operating rooms, direct admits, et cetera. So you can plan with confidence around staffing, opening flex units, et cetera. Whole other set of capabilities also that helps you understand the core components in the hospital that are most contributing to your length of stay. So is it that your MRI turnaround times on Thursday nights are super high, or that cardiology isn't reading stress tests on the weekend? A whole set of benchmark analytics that help you understand the interval, the relative impact that each of those core processes is having, so you can invest accordingly. The outcomes across all our customers have been very consistent. We typically see anywhere from a 15 to 30% reduction in excess days, typically within the first 3 to 4 months after going live. So an immediate impact. For a 600-bed hospital, that's like 30 beds of additional capacity and $6 million in annual savings. As a clinician, I'd say the most satisfying thing here is also the impact we have on things like ED boarding. So a 15 to 20% reduction in ED boarding and a 12 to 18% increase in transfer accepts. So that's the whole name of the game here, is like, let's help health systems meet their mission, reduce burden on frontline care teams, improve the patient experience, and bring down cost. Some examples of how we do that in case folks are interested in how we integrate directly into the EHR. And this is variable across our customers. We spend a lot of time trying to understand how they do their work today. So we make sure we integrate that intelligence into those existing workflows in a way that best supports the care team. In this example, we call this side panel. One of our customers rounds on their patients in Epic using side panel, and it has all the information that's necessary and sufficient for that care team to have highly impactful MDRs. You see that discharge planning assistant operating at the top here. We're populating milestones in real time, and you see insights from that case manager assistant. When there's opportunities for action, whether it's prompting an order or identifying an order that can be moved to outpatient or a CDI improvement opportunity, we can introduce that in real time in existing workflows as well. So, imagine a patient that meets criteria for severe protein calorie malnutrition. Our model is able to identify that, prompt the provider by actually pre-populating an order for a nutrition consult that they can then accept, and even give suggestions to that provider for how to incorporate appropriate documentation into their progress note to make sure you're capturing that clinical complexity. Again, the whole idea here is let's make it easy for care teams to do the right thing. Let's build it into their existing workflows so that it happens reliably and you get the patient flow outcomes that you're driving for. All right, whole bunch of me talking. I'm going to turn it back over to Chris so he can talk about the journey that Boston Medical Center had.
Thank you, Jason. I think we had the previous slide. You want to go back one? So yeah, I wanted to actually spend a minute here that our partnership at Boston Medical Center with Cuventus began in 2020. And it was in the fall of 2020. I remember distinctly that we were at our executive meeting, and we were being asked, like, are you sure that you want to take this on during COVID? Because no one can forget 2020. But given our need to impact our length of stay and realizing that standardizing multidisciplinary rounds was key for that, we signed on with Cuventus and started using their Pathfinder tool. And over the years, our partnership has evolved, and it's definitely changed the way we operate in the hospital. And the solution has evolved too a lot, and during that time, and it's fully embedded within Epic. So you can move on to the next slide. So there were three key goals for our institution when we implemented Cuventus. The first one was to standardize discharge planning for every patient. And by this, I've spoken briefly before that one of the challenges was to make sure that every single unit, every single service does the same thing, that there's uniformity, so that everybody understands the language and everybody understands the goal. And this was provided by a standardized script. We went around the different services, different units, ensured that every member of the care team, nursing, ancillary service, the physician provider care team, they all understood what the script was, had opportunity to ask questions, understood their role at multidisciplinary rounds. And we had iterations of that process, definitely over the first few years, and created a standardized way of doing things. It clearly was not easy to start off, but we met the challenge, and we were able to do that effectively. The second goal was to reduce manual work. As Jason was just showing, the tool actually helps us to get a lot of things automated, and helps us to think through what needs to happen for a patient relatively quickly, so that effective and efficient care happens in a reasonable time. It creates satisfaction, not just for the care team members, but also for the patients that may be waiting for a test or a procedure. And we've all come to that. We've all experienced that, where we say, oh yeah, you're going to get this procedure today, and then it doesn't happen. They stay NPO for the whole day. But we identify those barriers ahead of time and are proactive about it. And that definitely goes on to the third goal, which for most institutions is creating capacity, especially in an environment where the resources are strained and where we want to make sure that we make the most out of what we have. We were able to do that. We did it without adding new beds. adding headcount, and improved our efficiency overall. Um, so in order to achieve those goals, we need to do a few things. The first one was to make sure that we can sustain this. Anytime we start something new, there's a lot of enthusiasm, a lot of energy. People get excited. They see the results right away. But how do you keep that going? How do you maintain the momentum? You need a culture shift. And using the leadership rounds is something that we instituted. And we were able to provide feedback both at the unit level as well as the service level to ensure that these processes are the workflows happen on a consistent basis. We have 7 days a week rounds, and we used to show up on weekends as leaders of various sections and services to make sure that things are happening the way we expected them to happen. And the second way we achieved it is to create to create a workflow that's easy, but also the right thing in terms of patient throughput. The third one was to focus on the discharge plan. Make sure that the members of the care team are familiar with the estimated discharge date, the disposition plan, and what the milestones are in order to achieve that. And finally, we were able to provide data. So every month, I facilitate a monthly inpatient medical director, nurse director meeting. Over the last 6 years, every single month, we've shown data as to the percentage of teams that attend daily multidisciplinary rounds. We actually show the data based on weekend attendance and weekday attendance, and the directors are there. This data is also fed to the, it's sent to the chairs of the various departments. So everybody gets the feedback as to what their expectations are and how they're meeting those expectations. I do want to mention one thing is that we clearly drew a line that connected attendance at multidisciplinary rounds with improving patient throughput. And that was important to demonstrate to the teams. And once they saw that, the results they spoke for itself, that it wasn't a heavy lift to convince teams. So we had very clear expectations, which teams go when. We had standardized times. Everybody knew what their role was. So that in a large part is the reason why we were able to achieve success. And it doesn't stop. Like, we have to keep doing this. We every year we have a reboot of this whole process. Every quarter we have like a lunch and learn so that teams understand, are we all saying the same thing when we define a patient as medically ready? So these are important things for us to keep reinforcing on an ongoing basis.
Chris, kind of like thinking through your experience here, I'm curious what, obviously Q card and automating a lot of this in the EHR for your care teams was important in making those MDRs repeatable and efficient. I think of having been a CMO, I know sometimes how hard it is to get providers to a multidisciplinary round consistently. I think one of the greatest things we can do for them is to like show that we're using their time efficiently and that they feel like when they're there that it's really meaningful. How did you? I'm curious how you. What was that journey like with your own providers? Like how did you get them to meaningfully engage? What was successful and what are the areas where maybe you still have more opportunity?
Yeah, I think I would start off by saying it's not easy, and also it has to be an ongoing process. So the two ways we were able to accomplish it is both a top-down and a ground-level approach. Top-down meaning sharing with the chiefs, section chiefs, chairs of the department, the medical directors, the importance of attendance at multidisciplinary rounds. And as I mentioned, we used to have, we don't do this anymore because people show up regardless of whether we had, we announced a winner, like, this particular service attended 85% of the time, daily multidisciplinary rounds, and we had like an award for them. We don't do that because everybody's doing it right now. But in order for us to get that buy-in, in order for us to create that culture change, it required, as I mentioned before, leadership rounds on a weekly basis. We had scheduled attendance by the department chairs and section chief at board rounds, so that people understood the importance that as a department, as a section, the value of the care teams attending board rounds. And the second thing is at the medical director and at the department, at the residency program level, because we are a teaching hospital, we actually went to, we had like town halls with the chief residents that the chief residents had coordinated. And we actually got feedback from the residents asking them what works and what didn't work, and tweaked the expectations. We moved the timing of the attendance. We used to have it earlier than what we have right now. And so listening to feedback, I think people understood, like, yeah, it's not something that as an organization, as an administrative, at the administrative level that we're pushing it, but it's really demonstrating to the care teams that this is really about the patient. It all comes down to that a delay of care, delivering the right test at the right time, identifying the barriers proactively, and engaging with the families in terms of post-acute care placement early on in the hospital course actually helps the patient more than anybody else. So once we were able to communicate that clearly and effectively, and it took time,
yeah.
But it really helped us achieve the engagement to the question that you asked, Jason.
That's a great answer. Thanks for sharing that. I saw that Savannah asked a question in the chat. Did you have to make any optimizations within your EHR before go live with Qventus? I think I know the answer to that, but I think it's direct.
Go ahead, Jason. Yeah.
No. I mean, I think the answer is none, right? Like, I don't think there was anything you had to do.
No.
Yeah. And I would say, Savannah, so one of the strengths of the way we build our machine learning models, each of those models sits on a feature set that has hundreds of individual features. So labs, vitals, problem list, medication list, test results, we're reading notes, hundreds of features that power those models. So we're able, so in health systems, for example, where they make great use of the problem list, which is the minority of systems, that problem list data can be valuable to the models. But in all the other systems, that problem list isn't very helpful, right? So like a patient may come into your emergency room with a principal diagnosis of shortness of breath. If you're basing an EDD and a disposition off of such a generic, principal diagnosis, you're not going to get very far. But if you have a model that's complex enough to look into that patient's chart and see that the ED doc ordered a chest x-ray and is treating the patient with azithromycin and ceftriaxone, and the patient's on oxygen, and someone sent a urine streptococcal antigen, and the white count is elevated, that model can identify, hey, this patient likely has community-acquired pneumonia, and we should treat them like other patients that have moved through Boston Medical Center who have community-acquired pneumonia. But the EDD and disposition for this patient isn't going to be like every other patient that had community-acquired pneumonia, because, this patient's also on Cinemet, and maybe their problem list isn't up to date, but the model's like, this patient's on Cinemet, they probably have Parkinson's disease. This is probably going to be a patient that takes a little bit longer than usual to get better from their pneumonia. The key thing here is that you have models that are robust enough to understand how different each patient is, how different each hospital is, each health system is, so you're setting appropriate targets for your frontline care teams. It's really critical for engagement, particularly by the providers, I think, that Chris was describing.
So Jason, I want to respond to that question and another one, if you don't mind. To the question of did you have any make any optimization within EHR? That was actually, I remember when we initially had the conversation back in the spring of 2020, we obviously didn't anticipate, we hadn't actually had the COVID pandemic hit at that point. But we actually, one of the reasons we went with Qventus was because there was no reason to make any further optimization. I distinctly remember our IT leadership say that if we don't have to do it, if it's not going to be much of a lift for us, we can sign on. And that actually was a selling point for us, just to clarify that. I also wanted to address the question about how much resistance have you faced from the employees. You're always going to have naysayers who say, yeah, it's another system, it's another thing. I need to log into another stuff. But the full embed in Epic actually uh, took away a lot of the resistance. Once we were fully embedded within Epic, it was one system, one click. Everybody could see what was identified as on the storyboard. And everybody knows this is the EDD. Actually, as a matter of fact, last week I rounded with the resident team. I'm a direct care hospitalist, but I filled in for another person. And that was the first thing that the residents were focused on. I was extremely proud of them that, no prompting. They were focused on this is the EDD, these are the barriers, this is the dispo, and the way they presented really, to me, is a testimony to the fact that people got it, they got the message. So you will have resistance if you haven't adopted this, but the way to do it is to show the benefits and show the results.
Yeah. Thanks. That's a wonderful question. And everyone probably missed it because Chris told us before we started the meeting, but Chris's office is near the ED bay. So you can hear the ambulances in the background. I'll also share that this was an important journey for us as a company, actually. So we had a solution 5 years ago, an inpatient capacity solution. It drove outcomes. We reduced length of stay, and BMC was part of this early generation of the solution, but it lived outside of the EHR. So people had to sign into a separate system. It was one of those things that, again, executives liked it because it drove outcomes, but the front line didn't. And it was like getting people to eat their vegetables every day. And one of the important lessons that I think we learned early on was that, first of all, it's the right thing to do for care teams to embed this in their existing workflows. It's not fair to heap more tasks on people that are already overburdened. I think of those poor nurses, how many more things are we going to make part of the intake assessment? Right? We need to actually find ways to reduce burden on folks. And so embedding the solution directly in the EHR is the only way to do that. It's also the only way to get repeatable results. If you're expecting people to go out to an outside system with consistency, it's not going to happen. And so that's why the solution today literally lives and breathes inside the EHR. There is no Qventus inpatient solution that exists outside the EHR. It is entirely embedded in Epic and Cerner. And it's because that's what's the right thing to do. And that's the way to get impacts.
And case managers actually, Jason, love this. I remember the same case managers who were, because they are the ones who are the drivers of multidisciplinary rounds. And the fact that the full embed happened, they love it. They don't want to change it. Anytime somebody sees me you're not planning to change this, are you? I'm like, no, it's working. So why do you change it?
Yeah, I saw a question from Rohan. Yes, it's applicable to Cerner as well. The integration points in Cerner are obviously different from Epic. We end up doing a little bit more build on our side to make it as robust in a Cerner system. But it's essentially the same user experience on the health system side. Does the solution review the patient payer and determine the most appropriate next site of care? Yeah, Devin, great question. So the disposition models, I think I mentioned the discharge planning assistant populates both an EDD and a disposition. The disposition models also pull in hundreds of features to determine that optimal disposition. It's a different problem space, honestly, than EDD. Payer can have an impact on it, but oftentimes it's also, how has that patient moved through your system before? Did that heart failure patient go to skilled nursing facility last time they were at BMC, or did they go home with home health? How do similar patients discharge from BMC? Payers is one of those things that we actually work closely with health systems to make sure we're including in the right way. We don't want to deprive, for example, I think it's in Missouri, state Medicaid won't pay for skilled nursing facilities. So the question becomes, do you not suggest skilled nursing facilities for patients that otherwise it appears appropriate for? And so we find ways in those kinds of situations to say, listen, this is what the suggested disposition would be. This is what's available for this particular patient. And then we customize that to each individual health system to make sure we're giving them the right information to make the right decision for the patient. And again, a place where we pull in things like AMPAC score and trends in AMPAC score to inform that disposition as well. Knowing that can change. Like sometimes you make a plan on day one, but patient gets better or patient gets weaker, and that plan needs to change, and we need to make sure we're changing it in real time so we can get ahead of that whole referral cycle. Well, I think probably I suspect we'll have some more questions, but let's, if you don't mind, Chris, let's move into the results section.
Sure. So, what's the impact that this had at our institution in terms of capacity creation? We were able to see 1,157 more admissions with an 8.6% increase in discharge volume in 2025. As a result of the 18% reduction in mean excess days in 2025. I do want to also mention that people have gotten more educated about terminology like excess days, avoidable days, and the frontline teams. I mean, people who are in the data world would actually know this stuff. But using this tool has also helped us educate folks that they understand the importance of this in terms of operations. It's actually resulted in a 25% increase in discharge volumes since go live. Next slide.
Thank you. Thanks, Chris. Yeah, here's some more of that data. So I think this shows what you were just talking about on the last slide, that from the beginning of 2024 to the end of 2025, you saw a pretty significant increase in discharge volumes, but at the same time, we're able to reduce excess days by, if I'm doing my math right, 0.71 days over those 2 years. I'm curious, has your CMI, like other health systems, has your CMI been going up?
Yes.
Yeah. I think that's the challenge. That's the challenge everywhere. We're caring for sicker patients, and if we're going to have capacity for them, we need to figure out how to get them the right care at the right time so they discharge on time. This is your slide, I think, Chris.
Yeah, so I wanted to actually talk a little bit about why we've continued our partnership with Cuventis over the last 6 years and counting. I think the highlights of this is that the close partnership is resulted from the responsiveness as well as the frequent touch points that we've had over the years, a good understanding of what the clinical workflows are, and how that is applied to our institutional needs. I think that's the key thing. It's tailored to meet the needs of our institution, the needs of our patients, and how can we flex it to meet the needs of the care teams? Because all these three are important. So there's a willingness to adapt to what the needs are and be flexible in order to evolve as the needs of the organization evolve. A great example is that we rolled out Hospital at Home back in the fall of 2023. We went live with our first patient in 2024. We've seen hundreds of discharges over the last 2 years. And all along that journey, those who have Hospital at Home would know that identifying patients is a big deal. And Cuventis has helped us and is helping us actually, as we speak, in the process of the best way to identify appropriate patients. And finally, I think there's a willingness to receive feedback and continuously improve the model so that we can actually get more out of the system, more automation, less manual tasks, more involvement. So I think the partnership is really key, the responsiveness, and it's just teamwork. And so it essentially is allowing us as an institution to continue and grow our partnership and work with Cuventis.
I don't know if you'll remember this moment. We met, I don't think it'll surprise anyone that we talked a little bit before this, before the webinar, and we were talking about the idea of partnership. And you immediately mentioned Shweta, who is one of our customer success partners. And I loved that you knew her by name. I think that's so different than what a lot of us experience, and I still practice as a physician, but a lot of us experience with technology companies. It's these faceless people who drop like a piece of technology in our laps and kind of wave to us in the rearview mirror. I think one of the things I'm proudest with of the work we do is folks like Shweta and other people who take a deep interest in our customers and their work and their challenges and are responsive. Any more? That's me kind of bragging on folks on our team, but any more you would say there, Chris?
No, absolutely right, Jason. I think when we've identified that something could be tweaked and we want to make a little change, it's not like, oh, we can't do it. It's like, okay, how can we help you, and how can we fit this? And we'll get back to the technical team and we'll talk about it and get back to you. And it's not like we're waiting for months to get back to receive an answer. It's a matter of days. And so I think we've all worked with technology solutions for a while. And I think the quick responsiveness and the willingness to listen from the frontline teams and from us as institutional leaders is really impressive. So, I love working with your team. I love working with them primarily because they get back to me very quickly, and they're willing to brainstorm with us solutions to the problems that we raise.
Well, and I'd say right back at you. I think some of the best ideas for our solution come from our customers. I'm super excited to meet with Tyler and Kate and other members of your team next week to go over those hospital and home outputs and figure out how we can share that model with other customers. Like there's so many opportunities today in healthcare, and sharing that knowledge and being able to bring it to others is super cool. So thank you. Thanks for the partnership.
Absolutely, Jason.
Well, I think we have we have a poll question left here, and then we'll move into the more Q&A part. Curious here of folks that are on, how confident are you that your current technology will meaningfully reduce excess days and ED boarding times in the next 12 months? This feels like a little bit like a self-serving question, I have to admit, but we'll see what folks say. I'm just waiting for the submissions to start ticking up. We've got 1. 10. Okay, maybe there's just a little bit of a lag. I think when I think about this question, I think of all the things we've tried before, and hoped would work. One of the things I've certainly encountered talking to health systems today is there's almost reluctance to tackle this problem yet again. Like it's such a pressing problem, but all of us have been part of some performance improvement or other kind of effort to reduce length of stay, that it just feels like a never-ending battle. I think I'm curious how you feel about it, because not even like just speaking of AI in general, having kind of been part of the quality movement as part of my career, I feel like I'm more optimistic than ever in terms of finally having, instead of us being, the victim of meaningful use and turning us all into clerks, that we're finally getting to a point where we're reducing the manual burden on care teams and having an impact and achieving that triple or quadruple or quintuple aim, whichever version you use, of reducing cost, of improving the patient experience, reducing burden on care teams, in promoting equity. Where would you agree, or you see things differently?
No, I think I agree with you, Jason. I think the fact that we have come a long way in terms of automation and pushing to the teams who have a lot on their plate already in terms of delivering bedside care. We talked about the complexity in terms of a medical management standpoint, but in an institution like ours, and there are other institutions, we're not unique in this, that serve a very vulnerable population, a safety net situation. I think there's more pressure now than ever before in terms of dealing with the patient, the caregivers, the families. So to the extent that we can reduce anything else and take things off their plate is huge. And I think that's how you actually get teams involved, get teams engaged. I go for weekly rounds to different units. I pick a unit a week. And it always kind of excites me when I see people not leaving the queue, waiting in line. And even if they have one patient, they're coming and talking about that one patient. And we have an expectation that if you have 3 or more patients, you come to that unit, because we're trying to regionalize teams on the same floor. So 80% of the patients can be discussed in the half an hour window that they have. Uh, but it always kind of is very impressive when teams are waiting for that one patient and talk about it. And the value of providing information to the care teams, taking away, uh, ensuring that the time that is spent at the bedside is meaningful and effective. I think that's what I'm confident and optimistic about in terms of the technology and the way the, the direction it's headed.
Yeah, yeah, agreed. Well, here are the outcomes. I really want to talk to the people who are very confident that their EHR has what they need to reduce excess days. You're 1 out of 20 of our respondents in, I want to know where you practice. But it looks like 76.3% are over 3/4 either not confident or not very confident, which I think is, again, just kind of a reflection of all the things we've tried before and been frustrated by, and why custom building tools specifically to promote patient flow and hardwiring them into existing workflows is just so important. Particularly if we're going to ask folks to do this work again, we need to do it in the way that's most supportive of those care teams. Well, I think we're on to Q&A. Let me look through. I know we were tackling some of these questions throughout, but let's see which ones maybe we didn't get to. I see one from Ben. We've built a suite of dashboards in our EHR, Epic, to help with predictive analytics. How does Qventus integrate with Epic dashboards built to help with patient flow and capacity management? So, Ben, we never want to duplicate what other resources you already have. Like, you all have invested a lot of money in an expensive EHR. I would say, as a practicing hospitalist, if I could work in any EHR, it would be Epic. I currently work at a hospital that has Meditech, and I survive just fine, but Epic's great. The thing we've heard from most of our customers is that a lot of the valuable analytics you do need to build yourself, that the stuff out of the box or having to dig for stuff doesn't necessarily always yield the best results. The other piece is that our goal, as much as possible as a company, is not to expect people to go look at a set of analytics and then take action, but to operationalize those analytics within the EHR to drive the action that we're looking for. So instead of identifying, hey, it looks like patients that are waiting to get discharged, their echo often doesn't get done in time and they end up staying an extra day. Like, rather than exposing that as a piece of analytics, we would embed that prioritization directly within a flow priority queue for your echo manager to make sure they're seeing the right patients at the right time. And then we build robust analytics around those automations so that you can monitor performance. So how often are high priority echo orders getting completed? What is that variability by day of week, time of day, season, et cetera? So you can very quickly pinpoint where your opportunities are. All of our analytics are actually persona-based. So there's a set of analytics for your physician leaders, a set of analytics for your case management leader, a set of analytics for your imaging leaders, your therapy leaders, et cetera. So that if I'm a provider, I can go in and see, okay, how good are my hospitalists at identifying early accurate discharge plans? How often do they respond to these kind of prompts? What is the imaging utilization of Dr. Cohen versus Dr. Manasseh for this particular basket of patients? Or what is, how many consults does Dr. Cohen use compared to Dr. Manasseh to care for similar types of patients? The whole goal here is to give you those analytics, but also to operationalize wherever possible those insights, rather than relying on, again, busy teams to go see an insight somewhere and then go take an action.
Great, Jason. I was going to address question 22, if that's okay.
Yeah, please.
So when patients are marked medically ready, we know that they are ready to have a discharge order placed, and they have some other barriers to transitioning them out of the hospital. And as the example in the question, lack of support at home. So we actually have a team that we created several years ago, even before Qventus, the Central Flow Unit. And what Qventus has done is it helped us to prioritize these patients, because we can go to the discharge daily report and we can see those patients that are marked across the board in different units who are medically ready with the EDD of today that can't go because they don't have whatever, they don't have support or they don't have a ride, or they don't have medication, they don't have whatever the non-clinical need is. We have members on the central flow unit representing different services. So we have PT and we have case manager, social worker, our operations folk, and we also have a flow medical director on that daily huddle that we have that actually monitors the email. And so our teams actually are well aware to escalate such patients to the central flow unit. Now, sometimes they escalate all sorts of patients, but we typically have the discharge report on the side. We know who actually has everything ready, but all they need is XYZ. And that's how we operate. Now, are we successful 100% of the time? No. But 8 out of 10 times, we are successful. If we don't get the patient out today, we get them out tomorrow. Where in the past, those avoidable days would have been 2 or 3. I mean, ideally, it should be 0, and that's what our aim is. It's less than 1 for the most part, I think.
Thanks for that, Chris. The only thing I'd add there is we didn't get a chance to share our capacity intelligence reports today, but those reports include things exactly like Chris was mentioning. So who are the patients that still are supposed to discharge today, and what are the things holding them up? Those models also identify patients that look highly likely to discharge today, the ones that are on glide path, as well as the patients that are less likely to discharge. So you know where to focus your attention. Those same models also identify patients that might not have an EDD of today, but appear the most dischargeable, so that when you're really scraping for beds, you actually know where to look instead of boiling the ocean and calling every single floor to figure out who could possibly be discharged. Like, here's the 14 or 15 or whatever it is patients where you have the highest opportunity. So really trying to use folks' time wisely by focusing on the places where they're likely to have the greatest impact. Just looking through the questions, are there any we didn't get to? How does Canvas integrate? I think we got that one. Well, I think,
hey, Dr. Cohen, there is one question that we want you to address before.
Oh, yeah.
Thank you so much, audience, by the way. You guys have been great at participating with the polls and everything else. So many questions. We love this for both of our presenters today. But yeah, Dr. Cohen, Dr. Manasseh, simply, how do you make the business case for a third-party solution versus only using the EHR?
Yeah, I'll give that to Chris for sure.
Yeah, I think as Jason mentioned, and thank you for the question, as Jason mentioned, when we signed on with Cuventus, it was before the full embed within Epic. And so it was a harder sell to make a business case. I think what I had highlighted before was that we needed a solution that would work for us immediately, that would address the need for the 2 basic things that we were looking for. What is going to bring teams to daily multidisciplinary rounds on a consistent basis, and what's the tool that we can agree upon? At that moment, when the need was there, the only thing that we could actually land on was Cuventus. So even though it wasn't fully embedded within Epic, the leadership didn't take much thought. I remember the meeting lasted for just an hour or 2, and by the middle of the day, we got a go-ahead from the C-suite to go ahead with this. So I think the case for this couldn't be stronger now, given the fact that it's fully embedded within Epic and the partnership that it has yielded. I think one of the good things about it is that both the leadership at Cuventus and our C-suite have had ongoing conversations, once or twice a year meetings to see how things are going, to see is it still the right thing? Are we still doing the right thing by our patients? And it always boils down to what is the best thing for our patients? How can we make life easy for the care teams? And if this is what's going to be yes for both those questions, yeah, we'll keep doing it.
Yeah, I love that answer. The only other piece here I'll include, because I know folks wonder about it, is we obviously have flexible contracting terms. Like we're so confident in our outcomes, we'll go at risk. We demonstrate a 6 to 10x ROI across all our customers. From a financial impact standpoint, it's a no-brainer and no risk. And we're excited and happy to support health systems in meeting their mission. I'll wrap it up there because we're at time. Just give, again, a giant thank you to Chris. Thanks so much for participating today. And thanks to the Becker's folks for supporting the webinar. And just ask anyone, please reach out if you have additional questions, and appreciate your time today.
Thank you, Jason. Thank you, Becker. Have a good day.
Yeah, you guys were awesome. Thanks, Dr. Manasseh. Thanks, Dr. Cohen. You guys in the audience were wonderful. And of course, we want to thank Juventus for sponsoring today's webinar. As I said, you can access the data after the webinar. Just reach out to Dr. Manasseh or Jason, and we'll get that settled for you. You want to have a wonderful day. And yeah, thank you so much.